So today I'm going to be presenting this paper, Chaperoning Epigenetics. FKBP51 decreases the activity of D&MT1 and mediates epigenetic effects of the antidepressant paroxetine, which, in other words, just means FKBP51's role in the epigenetic pathway of the antidepressant paroxetine. Everyone has bad days. Everyone has woken up or gone through a horrible day in which they broke up with their significant other, their cat died, they bombed a test, and maybe they, let down their whole team and made the entire team lose in a match or something. I don't know. It's a bad day. It's a really bad day. And you feel really bad. You feel horrible. You feel disappointed in yourself, in the world. You feel like you can't do it anymore. You can't go on, right? But deep down inside you, in the back of your mind, you know that if you sleep on it, if you wait a week, maybe a month, maybe just a couple hours, you'll feel better. You know that you'll get over it. You'll feel happy again. Now imagine waking up every day expecting nothing but that horrible feeling. You have nothing to look forward to because every day is the same. Every day feels awful. Every day is disappointing, and you feel disappointed in yourself and the world around you. And no matter what you do, you never feel good about yourself. That is the closest analogy that I found to depression. There's a really common misconception that depression is just feeling sad. It's a mood swing. It'll pass, it's all in your head. But depression is not just feeling sad or down. Okay, it's not working. Down. You're gonna have to go without a presentation.
Do that to somebody. That's wrong.
Prepare for this.
Let's make me ever again.
I knew this could happen. Me? So prepared. Yeah, that was really But it's not just feeling sad or down, but it's feeling like you'll never be up again. Approximately 15.7 million adults in the United States have experienced at least one episode of major depressive disorder in the past year. That's 6.7% of the United States population. And if that doesn't mean anything to you, 6.7% is also the amount of Italian people in the United States. It's a large population of people who are affected by depression. I don't know how many Italian people you know, but I know a lot of Italian people. Okay. So, that's 6.7% of the United States population that is at risk for alcohol and substance abuse, obesity, increased risk of heart disease, social phobia, self-mutilation, and suicide. Clearly, depression is a very legitimate problem. It's a legitimate disease and not just a mood swing. And in order to fix that, we need to know what causes it. The problem with depression is that so many different things cause it. There is a huge list of, that's only part of it, of factors that contribute to depression, including genetics, biological differences, environment, stress, grief, physical illness, alcohol and substance abuse, and epigenetics. So today, we're going to be focusing on epigenetics because clearly this is a really multifaceted, complex problem, and we can only tackle one part of it at a time. What is epigenetics? Okay. Epigenetics is basically when genes are turned off and they become unreadable so that they are not read and turned into proteins, right? So genes can also be turned on and made more readable so that transcription machinery wants to read that gene more and create that protein. But for all intents and purposes, genes are turned off because we don't want to create that protein. One really important thing about epigenetics is that they're heritable. So this becomes so relevant because if you have an epigenetic setting that's on or off that lends itself to depression, then it's not just 6.7% of the United States population anymore. It's 6.7% of the United States population plus their kids, plus their grandkids, plus any other, their entire family. So epigenetics is something we really need to discuss more because it has huge implications not just for the existing population that suffers, but all of their family in the future. Okay, good? Questions? No? Okay. So right now, the only thing that we have to combat, truly combat depression, except for counseling, is antidepressants. 11% of Americans aged 12 and older take antidepressant medication. That is roughly the population of California, which, by the way, is the most highly populated state in America. And if that doesn't mean anything to you, that's 1 out of 10 Americans who are on antidepressants at every given time. A lot of people. So our question is, what do antidepressants even do? If 1 out of 10 Americans is on antidepressants, then we should know we should want to know at least what exactly we're putting in our bodies to manufacture happiness, right? We should want to know exactly what we're doing such that we no longer feel sadness anymore. So my paper is one of the first papers to really track an antidepressant at a molecular level and see what it's doing in our brains to make us feel better. In doing so, it's also investigating how epigenetics contributes to depression. Questions? Yeah.
If 5% of the population has depression, but 11% take antidepressants, does that mean it would be 16% total if 11% didn't take antidepressants? Or I'm a little confused about those numbers.
So one of the things about these numbers is that the one about antidepressants, the amount of people is age 12 and older, and the one about depression is 18 and older, adults. So they're not exactly comparable. Okay. So to get into my paper, there are a couple of really big terms that will come up and be confusing because there are a lot of them. Stop me at any time if you need to clarify what is what, okay? The first is paroxetine. Paroxetine is just the antidepressant that we'll be talking about, and among other things, it increases FKBP5-1. What is FKBP5-1? FKBP5-1 and FKBP5-2 will henceforth be referred to solely as 5-1 and 5-2. 5-1 and 5-2 are binding proteins that control different responses to stress, and they do this by competing to bind to CDK5. So whichever one binds to CDK5 determines whether or not they will activate, CDK5 will activate DNMT1. Visual representation. 5-1 and 5-2 are fighting over teddy bear and the teddy bear is CDK5. Whichever one wins, for some reason, also gets to determine whether or not they turn on the Wii that day. Good? Okay. So what is DNMT1? DNMT1 is DNA methyltransferase 1. And when it's activated by CDK5, DNMT1 becomes phosphorylated DNMT1, or pDNMT1. When you see pDNMT1, I want you to think activated DNMT1, doing its job. Its job is to add methyl groups to DNA to turn genes off. So I mentioned at the beginning of the presentation about epigenetics and how that's just turning genes on and off, and that determines which proteins get produced. pDNMT1 is a huge player in this because it's actually doing the act of selecting genes to turn off, right? And finally, BDNF. BDNF stands for brain-derived neurotrophic factor, and it's a protein that maintains and develops neurons. For our purposes, we care about it because increased BDNF is linked to decreased depression. And visual representation, a patient with major depressive disorder will have no or low amounts of BDNF. Sad brain. A healthy patient will have lots of BDNF. Happy brain. So the goal of our treatment is going to be to increase BDNF because it's linked to decreased depression. Now, as a disclaimer, BDNF is not the end-all be-all of depression. It's not going to solve depression. It's not a cure-all. But for our purposes, because we're targeting the epigenetic part of depression, the epigenetic cause of depression, we're going to investigate it deeper. Obviously, depression is such a complicated, multifaceted disease that it's not going to be solved by one protein. Okay. So we want BDNF though. Basics recap. 5-1 and 5-2 compete to bind to CDK5. Whichever one wins and binds to CDK5 determines, well, depending on which one binds, CDK5 can activate DNMT1. PDNMT1, or just activated DNMT1, will turn off the BDNF gene so that no BDNF protein is produced. And then that means that low amounts of BDNF are correlated with increased depression, levels of depression. That's a really bad place to end. We don't want it to end in increased depression, we want the opposite. So in order to do that, we gotta mess up this pathway somehow and reverse it. So what if we could block the activation of DNMT1? Theoretically, by blocking the activation of DNMT1, PDNMT1 would never turn off the gene would be translated, BDNF would increase, and therefore, theoretically, depression should decrease, right? Okay, so what naturally inhibits DNMT1 then? The answer is 5-1. Scientists had to find what naturally inhibited DNMT1 so that they could find a way to boost that to make it have a greater inhibitory effect. And they did this by increasing 5-1 and 5-2 to see which one, when bound to CDK5, would actually turn on PDNMT1. As they increased 5-1, you can see that there's a steep downward slope for levels of PDNMT1. And as they increased 5-2, there's a steep upward slope of PDNMT1. So this is just really clear. As you increase 5-1, you decrease. It blocks the phosphorylation of DNMT1. And as you increase 5-2, there's an increase in phosphorylated DNMT1. We're going to start building a pathway, guys. I know you're really excited. 5-1, bound to CDK5, inhibits the activation of DNMT1. Does everyone understand the notation? Is that good? Good stuff? Okay. Wait, sorry. Okay. So now that we know what naturally inhibits PDNMT1, we want to increase it. We want to up it so that it has a greater inhibitory effect, right? So the answer to do that is paroxetine. I mentioned at the beginning that paroxetine increases 5-1. It does a lot of other things, but for this paper, it's important because it increases 5-1. It's really, so if we look at this graph, it's really clear that as you increase 5-1, or as you increase paroxetine, the levels of PDNMT1 decrease. That's signified by like the lessening or the lightening of as you go toward the right. And that's just really clearly represented in this downward slope, that as you increase paroxetine, levels of PDNMT1 decrease, right? So what's going on? Increased paroxetine means increased 5-1. Increased 5-1, as we've already shown, will decrease PDNMT1. Paroxetine increases 5-1, which binds to CDK5, which inhibits the phosphorylation of DNMT1. Can somebody remind me why we don't want PDNMT1?
Because it turns off the genes and
Yeah. That's good.
are you is the antidepressant attempting to reach like a normal level of happiness or attempting to reach like a heightened level of happiness?
I would say normal, just because the patient or victim is depressed, so they want to reach a healthier level, but I wouldn't really know because I haven't. So, exactly. So PDNMT1 will turn genes off, as Melissa said, and we don't want that because that's linked to decreased depression. So now that we've found a way to inhibit the phosphorylation of that, to inhibit that turning genes off effect, we need to follow through and make sure it really has the effect that we thought it would. So scientists then investigated whether or not it was affecting BDNF gene methylation as it should be. As a reminder, gene methylation is when genes are turned off. Right. So scientists did this by looking at the methylation changes, whether increase or decrease, when they gave paroxetine to a wild-type mouse and a 5-1 knockout mouse. So a wild-type mouse would be a normal mouse that has all the proteins it should, and a 5-1 knockout mouse would be a normal mouse, but no 5-1 protein. No 5-1. Is that clear? So if we look at the gray, which is the wild-type regular mouse, all of the bars when they gave paroxetine to this mouse were like steep decreases. The amount of BDNF methylation, gene methylation, went down, which is good because that's what we expected. That's what we expected to, when we gave the drug, the methylation, it should stop this turning genes off effect. So what does that mean? Paroxetine decreases BDNF methylation and the BDNF gene stays on. But if you look at the white bars for the 5-1 knockout mice, they're all above the line. They increase, which is the exact opposite of what we were expecting. And this just goes to show that 5-1 is necessary for paroxetine to work. Clearly, when you take away 5-1 and you still give the drug does the exact opposite than it's supposed to. 5-1 is necessary. So, paroxetine increases 5-1, which binds to CDK5, which inhibits the phosphorylation of DNMT1. And if there's no PDNMT1, then there's no BDNF methylation. Therefore, the BDNF gene stays on. If the BDNF gene stays on, can somebody tell me what should happen to our BDNF protein levels? No?
They go up.
Yeah! They go up! That's exciting. So, next we have to investigate whether or not the BDNF proteins do go up. And they do. BDNF increases with paroxetine. So scientists determined this by looking at, they gave 2 different kinds of mice, either a control or paroxetine. And the 2 different kinds of mice are the same as before, a wild-type mouse and a mouse with no 5-1, a 5-1 knockout mouse. So I want you to look at these 2 on the left side. When you give a wild-type mouse the vehicle, or the control, versus when you give a wild-type mouse paroxetine, they both have 5-1, but the one getting paroxetine has increased levels of BDNF because it's darker. So this just goes to show that paroxetine is doing what it's supposed to, it's increasing levels of BDNF, right? But if you look at the bottom row, you can see that when a wild-type mouse and a 5-1 knockout mouse are both given paroxetine, the wild-type mouse has far more BDNF. What does this mean? Paroxetine does increase BDNF, but only if the mouse has 5-1. That just supports our earlier conclusion that 5-1 is necessary for paroxetine to work. Right? Okay. Paroxetine increases 5-1, which binds to CDK5, which together inhibits phosphorylation of DNMT1, and then inhibits BDNF methylation, therefore the BDNF gene stays on, and BDNF is expressed! Yay! So, why did we want BDNF in the first place? Josie?
Decreases depression.
Or it should. So that's the very last thing that they're going to have to investigate, not invest in, investigate. And that's the clinical data. 40 patients with major depressive disorder were treated with paroxetine. Then their depression was rated on the HDRS, Hamilton Depression Rating Scale. So lower values on this scale indicate lower levels of depression, so our goal is to reduce it. We want an increased reduction. So I want you to look at this graph with me. The x-axis represents HDRS reduction, which hopefully we want to increase that reduction. And the y-axis represents BDNF change, so increases and decreases. And I want you to follow the y-axis instead of the x-axis. As you increase BDNF, you also increase HDRS reduction. What does this mean? Increased BDNF equals greater HDRS reduction equals better patient response, because our goal is to increase the reduction. Lower HDRS value means lower depression, right? Okay. So, last time you'll have to go through, yeah, what's up?
So why, if they're all treated with paroxetine, right? So is there a reason why some of them have decreased levels of BDNF? Because it seems like a lot of them are below the 0%.
So this is BDNF change in clinic. So I'm guessing they all started at 0, right? And paroxetine just didn't work for a lot of them.
Okay.
Does that make sense? Because that's change, so it could have gone decreased. Yes.
And by lower depression, is that determined by behavior or mood when in the clinical trial?
In the clinical trial. So that's determined by the rating scale. So I'm guessing. I don't know. Sorry. I'll get back to you with that. I'm gonna guess. So paroxetine increases 5-1, which binds to CDK5, which together inhibit phosphorylation of DNMT1. And if there's no phosphorylated DNMT1, then you decrease BDNF methylation and the BDNF gene stays on. If the gene stays on, the protein is expressed, and therefore there's a positive patient response. What are the future implications of this? So, first of all, we just understood exactly what an antidepressant did at a molecular level. That's pretty impressive because, as I said at the beginning, we barely know what happens when we use antidepressants. With 1 out of 10 Americans using antidepressants at any given time, we probably should know more, but hopefully this paper represents the beginning of a lot more research and a lot more understanding about what exactly these drugs are doing to us when we use them. And second, even though I keep saying that epigenetics is only one factor of depression, it's really important because the more we understand epigenetic pathways, the more we can target it and treat it before it even happens. It's almost preventative because epigenetics happens before the gene is even translated. Instead of just treating the symptoms, this can hopefully stop it at the beginning, right? And it has the potential for future gene therapy. The more we can do with epigenetics, the more people we can affect, because it's, like I said, it's not just 6.7% of the United States. It's 6.7% and their children, and their grandchildren, and their entire families. So, thank you.